All right. Good morning, everybody. I'm Kate Vaughn, and I'm one of the doula consultants for TIMA, along with Sarah Tui. And I'm gonna do the share that opens today's meeting. And just a reminder that if we'd love to have folks um, reach out to Rachel if you're interested in doing this at a future meeting. Um, just an opportunity to share more about how you come to this work we're doing here today. And then I will pass it over to Rachel to do a little housekeeping before we dive in. Okay.
Hey,
Yes.
sorry, it's Maggie. I'm having a little trouble hearing you.
Oh, okay. Is that better?
Think so.
Speak
Because
up, girl.
you sound very quiet. I know you had an overnight shift last
Yeah,
night, so
like
I'm sure
I'm
that's
I'm half
contributing.
asleep. That's why.
Yeah, yeah. Okay.
Okay. I'll work on it. Okay, so just a brief note before I begin that there is like a very, very brief mention of infant loss in what I'm going to share. So I just recommend people take care of themselves. Um, Okay, so lately in my doula work, I've been reflecting a lot on how humbling birth is, and how being a doula requires a near enthusiasm for being humbled by both the feats and limitations of the human body and spirit, being humbled by the very thin line between life and death, beginning and end. And I've also been feeling more deeply into the truth that the day I'm not brought to my knees by this work is the day that I should leave. Um, when you look at the definition of doula or birth worker, one of the most emphasized descriptors is that we are non-clinical support professionals. And it feels a little odd to be defined by something we're not, but point taken. Um, we do not diagnose disease. We help people make sense of what comes next and become ready to let go of what might have been. We don't pass down predictions or recommend interventions. We hold families while they're in the valleys of the unknowns. We don't claim anyone's outcomes. We simply witness and reflect back what our clients have endured. And most times, what they endure is the breaking open of their very selves in order to deliver life into the world. And when death swoops in where new life should be, we also sit there in silence with the grieving too. There is something very humble about all care work, the washing of bodies and dishes, wiping tears and mopping floors, folding laundry and lifting tired limbs, and on and on. Its humble nature is, in fact, where care work's greatest power lies. We don't show up for this work because we know how things will go or we know how to fix them when they go wrong. We show up because we commit to being rooted and present in what we don't know, what no one can fix or control. We show up ready to be taught once again how little we know, but to keep on taking one more breath, doing the next right thing, and staying in the room until birth is done with us. Because we believe that it matters how someone feels as they release a fresh heart into this pain ridden world. It matters that someone witnesses and honors what happens in those birthing rooms, where a person digs deep into herself past every fear and doubt she's ever had and finds the will to keep going through the impossible. It matters that people understand their care, feel held in their hopes, soothed through their fears, and that birthing is something people do, not something done to us. If somebody were to ask me what being a doula is like, I might ask if they've ever stood on a Maine beach during a big storm and felt the ocean roar and pound against the sand and the stones. Labor and birth are the storm and the sea, and I'm one tiny piece of that humble rock-bound coast. And I'm just grateful to be there when the waves are crashing and after when the sun warms the earth again. And that's it. I'm going to hand it over to Rachel. Thank you.
Thank you so much, Kate, for opening for us. If you'd like to do something similar, we really encourage that. Love to hear a little bit from everyone about this work and their passion for it. So just a few administrative updates for everybody. First off is that the payment system that some of you logged onto and created an account for, that is underway. We have not forgotten about it, and we should be ready to get going in February for that. So we will keep you updated as we get more updates, but as for now, February should be the time that that gets rolled out. And then second note is just on meeting time. We know that doodle polls can just get like a lot overwhelming. So discussing with Sarah and Kate, we thought about Thursday and Friday mornings. So I'm going to launch a poll, and the option are to keep it Friday mornings, or going forward, we can rotate it between Thursday and Friday mornings. So for example, next month we'd hold it on a Thursday, month after that Friday, and so on and so forth. And just answer the poll, and we will schedule next month based off of that. So I'm going to launch it, and I'll give everyone a few minutes. I know that some folks are driving, so if you want to share your response via email or something else after the meeting, that's totally fine too. It's not going to be decided purely based on poll too. Right. Seems like we got about 80%, and it seems like Thursday, Friday rotation seems the best. I will watch my email today if more people submit comments, and we will do our typical follow-up email by the end of next week. So you'll be able to get this meeting time in your calendars. But that's all I have for administrative updates. And I will pass it off to Sarah and Kate again. Thank you, guys.
Thank you, Rachel. It's great to see everybody this morning. I really appreciate all of you being here. On the agenda today is to look at those draft recommendations that were sent after the last meeting. And I was really thrilled to see some engagement and comments and questions left. So I think what we'll probably do is take a lot of the meeting to just go through that document together and talk about comments, answer questions that people have. This meeting is not intended, this document is a starting point that we'll be workshopping a whole lot over the next bunch of meetings. So that was our idea for today, was just to go through that and as a starting place and try to get through the whole document with like kind of an initial round of questions. And then if we have time to dive into one area, that area around eligibility and what qualifies a doula to bill for MaineCare services seems like sort of the first piece in this process that we need to get clear on. And so that deep dive discussion might get left for the next meeting. And if we have time today, then we can start diving into that. But the hope for today was to kind of look through the whole document and address whatever is there for comments and questions. Does that sound good, Maggie? Rachel, did I get that right? Kate?
Yeah. Yes. Sounds good.
So we went back and forth a lot about whether to share the document itself on the screen or whether to make slides. In the end, we opted just to put the document itself up on the screen and go through it. And if people want to pull the document up on their computers, you're welcome to also do that so that you can scroll through it on your own, whatever you feel like works best for you. And I recognize that there are people who are tending children and who are driving children around or who are in the car. So no worries for that. And we will, again, this is recorded. So if you miss bits, you can go back to it later. And there is always that sort of question box that Rachel set up that people can put questions into separately from the meetings if they want to. Okay, so just to get started on this, and if people have comments or questions as we go, feel free to. We can't all see each other anymore because the screen is being shared. So feel free to just kind of speak up. A hand raise is probably No, I'm not going to see it. Um, so again, these are draft recommendations, and I just really want to stress and continue to stress that this is something that Maine Doula Coalition drafted in 2024. They're based on sort of findings from the Maine Doula Workforce Assessment. They are based on a 2024 poll that we did with doulas in the state on sort of opinions around MaineCare implementation, which was a survey that we did. So there's a lot of different places that this information is coming from, including getting pulled from what other states have done with MaineCare coverage. So what I want everybody to know is that this document was created prior to Maine even receiving TIMA, and so this is a starting place. This was an existing document. It's just a starting place for discussion. It's not something that we are imposing or that that it's just a starting place. So I really want to stress that because I want everybody to feel like they have equal input and ownership over this process. So the document starts. Does anybody have anything they want to add just initially or questions about that? Great. I just want that to be really clear because I do want this to be a collective process, and I recognize that we're putting a document in front of everybody with a lot of kind of things already already included. So there are some definitions. Rachel, if you want to scroll down just a little bit. So a lot of the other states have definitions about what a doula is, what a doula group practices, and what doula services entail. So people can read over that. Does anybody have questions, comments about that definition of a doula? It's a non-medical care worker who provides emotional, informational, and physical support to individuals and families during pregnancy, birth, and the postpartum period. And then is very specific to say that doulas are not licensed or clinical healthcare providers, and they do not require supervision. Anne-Marie, I saw that you left a flagged this. So there's also a definition about a doula group practice, which is not something that I don't think we have a lot of in Maine. They're more common in other places where there are, groups, a lot more doulas and a lot of doulas working together. So there's a definition here for that that could be included in recommendations, just so we have it, so that if that's something that becomes more common in Maine, that it's included in a definition. And then this piece on defining what doula services are, I think it's important, and it's something that we should probably have discussion around. So Anne-Marie, do you want to come on and talk about this question you had about HIPAA?
Yeah, I was just wondering specifically what the HIPAA protections would be in terms of education for doulas, because that's obviously a sensitive area
Yeah.
for patient history, HPI, and I'm not really sure how that is taught or what the process is
Yeah.
already.
No.
There's probably a process, I'm sure, but I just wanted to address that because, that's an area of legality.
Yeah.
So I just thought I'd ask what the process currently is or what it would be moving forward.
Yeah, it's a really good question. And I think there are some sort of practice management platforms that are geared specifically for doulas. Kate's actually trialing one right now called Doulato that is being used more and more. That is, it's a HIPAA secure way for doulas to keep charting and do scheduling and all of those kinds of things. I think that this is going to be a big learning curve for a lot of doulas to be learning how to keep records in this way. I'm also an acupuncturist, so I've been doing this for 17 years and I'm very familiar with how to do that. But I think this is going to really probably be something that we're going to need to provide. Somebody's going to need to provide some extra training on. I don't know if there's doulas that are here that can speak to, just because I haven't done, I wasn't trained through a course. So are there doulas here who want to speak to that a little bit and what the training looks like um, for patient confidentiality and HIPAA? Anybody want to jump on?
I think that it's really not something that's highlighted in the trainings I've taken. I mean, it's mentioned like you should be protecting your client's information. You should be keeping all of those documents private and secure, but there isn't a lot of sort of walking through that. At least in, I went through training with Doula and Cornerstone. And so I know it's mentioned that it's important, but there wasn't like a HIPAA training as part of the training. So I think it's listed later in this document as something that we would we might recommend to be required, that people go through a HIPAA training. And I think the platform Dulato, however you say it, is, that is newer than when I started doula work, certainly. And so I think, one of the things is about doulas is that there's a lot of variation in how people practice things. And so while we're not, our purpose isn't to regulate doulas as like a profession, but rather to like get really specific about what is expected of people being reimbursed through MaineCare. It's an opportunity to introduce people to more clear guidelines and systems and, training around HIPAA. I don't know, does that help at all, Sarah?
I can
Yeah.
speak to my training as well. I know, so I trained with Birth Arts International, and they didn't do HIPAA specific training. They were more emphasizing the importance of client information sensitivity. Don't talk about it here. Don't do these things. But it was broader and not really referencing that specific format.
Yeah, so I think this is one of these things that we're going to need to we need to put a pin in and potentially have an entire meeting where we are talking about what we might recommend doulas have for training. I don't know if that, I don't, we, to look at other states and see if state Medicaid agencies are providing some of that training to doulas. I mean, the question is always who provides the training? What is the cost going to be to doulas? And then also, these kinds of like, if, I think now the majority of people are keeping electronic records. And that's certainly a lot easier than having, the locked filing cabinets that we all had in the past. And so the question is also then, to make sure that those platforms what's the cost for those platforms, and is that prohibitive for doulas? So I think those are all like things to think about in terms of as we think about making sure that client information is protected, because it needs to be and would need to be, I think, as a MaineCare requirement anyway, if you're going to bill MaineCare. And then making sure that there's structure in place to make all of that equitable for the doulas that are MaineCare enrolled. Other thoughts?
Sarah, one thing I was thinking is just in terms of people in the community that are aware of HIPAA regulations, maybe partnering with CPMs, because I know, there are birth workers in the community, home birth setting or birthing center settings. So I'm sure, I mean, I can think of Morgan Miller right now who might be helpful in,
Yeah.
just talking about how she addresses like HIPAA guidelines
Yeah.
for her business and her work.
Yeah.
So
No,
that just might be a community stakeholder that we can talk to.
yeah, that's a great thought, Anne Marie, is to reach out to CPMs.
Yeah.
Other thoughts on that? Great. Um, oh,
Tiffany.
go ahead, Tiffany. Sorry. I can't see anybody, so I can't see when people are coming on mute.
You did say that earlier. I guess since we're talking about HIPAA and the maintenance of records, the other thing that comes to mind is whatever that training would be and wherever that comes from, to ensure that there's a mechanism for continued management of those records, even if a doula is no longer practicing. I feel like that's a pretty significant gap when you're talking about independent practices, solo practices, that maybe after 2 years, somebody stops practicing. And now what happens to those records? So,
Yeah.
I do believe that that has come up in other states around their Medicaid sort of eligibility criteria. Has been some, I've definitely seen some language about, after X number of years, this will, can happen with records and stuff. So that's a really good point. And I think we have models for that from other states that we can look into.
perfect. And then I just had one other thing that's not specific to the records. I don't know that this requires a change. I have been sitting with the phrase and the definition of doula, and they do not require supervision, which I totally agree that doulas do not require supervision. And I'm just wondering if there's different or better language, different connotation, whether it's to state that you guys are autonomous, although autonomous usually comes up with like legal and licensing. Maybe just a different framing, but I don't have a good suggestion as to what that might be.
Yeah, thank you, Tiffany. And I agree with you about that. And so that's something that we can look at and a place that we can make change and sort of bring back to this group. And if other people in your, if you're kind of cruising around looking at what other states have done and you find something that seems like a better fit than that, yeah, feel free to bring it to the group.
Yeah, looking at that, yeah, thinking about this point, like as you were reading it aloud, Sarah, I was like, oh, it's a weird way to end it, right? Like, and I wonder about what are we trying to convey? So I guess, I mean, it feels like maybe it's just repeating what Tiffany just asked, but like, what are we trying to convey with that phrase? Like, what is the importance of adding that or not, or phrasing it differently? Like, I'm not quite sure what is gained by putting that there, or do you know what I mean? Like, I'm just not sure what.
Yeah, I mean there are plenty of I think there are licensed providers that are required to be under the supervision of another provider. And so I think the reason for that is just to make clear that doula doesn't have to, supervision is oftentimes something that's just it's on paper, you know, Juanita is raising your hand, but I think that that's there to make clear that doulas are independent. We can probably find a different way to say that. I can see people raising their hands. Juanita?
What about just leaving it off? I think as doulas that we're in this meeting together today, so I think that would qualify as supervision, but putting that we don't receive supervision might be off-putting to individuals we work with or entities like MaineCare. Um, that was all. Those were my big musings.
Courtney?
Yeah, I was just wondering if we could just flip it to the strengths base and like our function independently, our independent team member, bring independent expertise, or like, I don't know. I think what we're talking about, how it's like the first part is deficit based to begin with, which I don't love. It's like, this person in this role brings so much. So how do we kind of just switch it from they don't require supervision, which again makes people maybe like question, to being like they're a professional that is a part of the team that functions independently, or just something to say like to highlight the strengths-based approach here.
Yeah, great. Tiffany, I think that's a great point, Courtney. Tiffany?
I think even as the person who raised this, I think there may be some importance in trying to convey that there is no requirement for supervision, if for no other reason that we're talking about Medicaid and Medicaid reimbursement. And I would hate to see us position doulas where they're only allowed to say bill incident to, meaning billing under another provider like a midwife or billing under a physician, right? So I think that whatever is trying to be conveyed, that should be a component. And for some reason, that phrasing is kind of pinging for me as maybe a little bit risky in certain contexts, but really appropriate in others. So, yeah.
Yeah, thank you. I think that we'll be able to come up with something very succinct that conveys exactly what it needs to convey. And I appreciate the thinking around all of that.
I think where they mention strength-based, like just looking at that sentence, it says doulas are not licensed or clinical, and they do not require supervision. So I think just taking out the nots, I think you can just say, um, like doulas are independent, non-clinical healthcare providers, if you take out the knots.
Yeah.
Yeah, I
Something
think
similar.
I struggle with the defining us by what we're not. Just I don't like it. And I know that it's really important to clinicians that we constantly emphasize we're non-clinical, but in defining what we are by what we're not, like that just feels sort of weird. And so yeah, I think there's probably a way around this that just feels more like it is conveying what we bring, instead of what we don't bring, which, you know, I don't know, even the non-clinical part, some part of that,
Mhm.
it's obvious to us, right? Like it's obvious to us that we're not clinical, but I know there's a lot of
Yeah.
anxiety about overstepping boundaries. And I think that's really the reason non-clinical has become such an important part of how people describe doulas. Um, but yeah, I would love to see more like, yeah, strengths-based language would feel better.
Yeah, I mean, I will say in terms of the licensure part, one of the questions that we get from people who don't know a lot about doulas, um, is that there is a misconception that doulas are licensed and it's unusual to not be licensed. And there's no movement nationwide to license doulas. And I think my concern is that without some language there around that there could in the future, be a misconception that, oh, well, it's licensure is needed. And so that's something that I'm just always aware of. Shannon, I saw you had your hand up.
Yeah, thank you. So I can't change my name in the thing for some reason. I'm Shannon. Maybe I have a penchant for overstating the obvious, but I guess as I look at this as an obstetrician, I love the strength-based approach and the definitions not being what you're not approach. Um, what I think about at the end of the day, like definitionally, how do I say this? Not protecting the service, but the liability concerns. Is that what we're talking about here ultimately? Like, because when there's an outcome that might not work, you know what I mean? Like, because oftentimes there's a sweep of liability that who's ever in that room gets caught up in a lawsuit. And how that language might shape being deposed or, for something. And I assume that's been taken into consideration, but again, as an obstetrician, that's oftentimes on the forefronts of our minds, in terms of who gets swept up and what the roles of the people are in the room and so forth. I don't know if I'm making any sense, but that that's what kind of comes to mind when I think about when you define the role and what's of the people in the room.
Yeah, it's a good point. And I think it's important to remember as we have this conversation that this is a conversation about that's very specific to MaineCare,
Mm-hmm.
and not necessarily specific to defining doulas in general for the state. And I think it's a good question, and that this language is pulled from what other states have. And so when I pull language from other states, I assume often that there's a reason.
Yeah, and I thought the same thing. I looked over that document. I said, no, this doesn't come from nowhere. So there's some wisdom behind what this is derived from, and experience and so forth. And so, yes, thank you.
Yeah, we didn't make it up. Juanita, did you have your hand up?
I did, and then I just took it down. So while we're all worrying about licensing and how that may appear, under the provider eligibility, there's all these requirements, and one of them being to obtain a national provider identification number. And that sounds licensee to me.
Yeah, you actually don't need to have a license to get an MPI. And we can have a whole conversation for people who aren't familiar with MPI numbers. And if somebody knows more, I have one as an acupuncturist, and there's probably a bunch of people here who have them, the midwives and the OBs and the nurses. But it's basically it's a number that attaches to your name. It's free to get. It doesn't cost anything, and it's there, I think, primarily to just have a numerical value on somebody who's providing care. Does anybody want to add more about an MPI numbers? Doulas, and this again is something that comes from other states where it's really common for doulas to have an NPI number, and on the actual form that you send in for billing, there are multiple places under each service line where you provide your NPI number more than your name, because people can have the same name and be providing care. Maggie?
I think, and I'm gonna call on Courtney too, because I know, Courtney, you've got an NPI, and I think with MaineCare, we want everyone to have an NPI just to make the billing easier. Is that right, Courtney? Is that kind of the
That's right.
Yeah.
So attach a number to a person.
Yeah.
For billing purposes. That's all.
It's the government way, right? We give numbers to everyone. So yes, that's basically what it is.
Lulu? Oh, there was a question. The chat's going so fast. Lulu, do you want to?
Yeah, I'm curious who oversees that number, like which organization is managing those numbers and keeping track of all that.
Nationally?
I think it's Centers for Medicare and Medicaid. Is that right, Courtney? I'm looking.
You can look it up. You can Google NPI number or National Provider Identifier. It takes about 5 minutes to sign up for one. We had questions last year around citizenship and getting a U.S. U.S. citizenship and getting an MPI number that are important to think about. But it is just attaching a number to a name, and everybody can look into that on their own. But it's common for billing.
Sarah, I was just thinking, this is just my own, I'm realizing this of how I was thinking of some of this language, and I'm realizing like what goes into a MaineCare manual for this policy is going to be weedsy and for no one else other than the doulas. And so I want to kind of differentiate what is MaineCare policy, and it's good and important to say what doulas are and are not for just what we talked about in terms of they function independently, they don't have to be they don't have a supervising provider. Like stating those things in policy is good practice. That way it's very clear and that will be changed, that will help it be evergreen. And that doesn't leave that for interpretation later. But then I think thinking of how public facing documents in terms of how doulas want to share about their profession your profession is something different. And so I just want to differentiate that. We're like, what is in the MaineCare policy, I think being very specific and in the weeds is good and okay, even if it's not like we're saying strength-based and the most, I think I just want to make sure that being very specific in MaineCare policy is good, and that's going to help this work and that section of policy be really super clear.
Yeah, thank you, Courtney, for saying that. And yeah, so these recommendations will go to Office of MaineCare, and then MaineCare will create the policy around that. And that document will be in the bowels of the maine.gov website somewhere. And as somebody, I sat on the board of complementary healthcare providers when the CPM licensure the rules were being written for certified professional midwife licensure. And I agree with Courtney that being incredibly specific is important, because ultimately what it comes down to is a lawyer looking at that and figuring out what it means and in what context it applies to some kind of a situation. So yeah, thank you for raising that, Courtney.
I'm wondering, Rachel, are you able to track and keep what's in the chat here so we don't lose any of those?
I believe so. Yeah, I'm working on figuring that out myself.
Okay. Awesome. Yeah, because I'm seeing like just some suggestions around language and just other things being dropped in the chat. And I think Tiffany offered some, like a full rewriting of the sort of definition with a suggestion, and just don't want to lose that. Thank you.
Other thoughts? We can move back to the document if we've sort of come to a place we can make some changes before the next meeting and find out more things. Thank you, Rachel. So, I think this is a big conversation, this doula services section, and how is that defined? This is a big conversation to have around how we want to potentially recommend that doula services are defined under MaineCare. Anybody have thoughts about what's written here? Rachel, I guess we're at the bottom. It's split between 2 pages. But if people have this pulled up on their own computers, and there's thoughts around this. And again, this is pulled from, this language is pulled from other states.
I do have one thing, and I'm sorry to be a little more vocal, but
please be vocal.
I do feel like a little bit further down in talking about coverage of doula services and what's included, there is a piece about providing evidence-based information on infant feeding and general breast/chest feeding guidance and resources. I just want to name that IBCLCs are international board certified lactation consultants are in an analogous parallel process of securing MaineCare reimbursement. And I just want to be careful not to maybe undercut where perhaps doulas are being compensated for infant feeding care, and maybe that impacts IBCLCs. And it might just be good to kind of learn what's going on that other side or that other work, because I believe maybe they're not like neck in neck, but I do believe there's a parallel process given change in law.
Yeah, absolutely. And I'm looking for where, I'm not sure if that language is on the screen right now.
I think it's core competencies, isn't it?
It's down under coverage of doula services, down a little bit farther. And And there is under postpartum services, there's a bullet there around providing evidence-based information on infant feeding and general breast chest feeding guidance and resources. And I personally think that, you know, that it's important to include that there, and also that language around that really emphasizes that this is like basic information. And I think we could probably work with the IBCLCs, and I'll make a note on that to reach out and and just make sure that we're clear that that support that doulas are providing is like baseline level support, and not necessarily support that a CLC or an IBCLC especially would be providing.
Yeah, I think it may be possible to make clear that like the guidance and resources really also includes like making referrals to lactation professionals, right? Like trained lactation professionals, or certain, you know, to name CLCs and IBCLCs. But I do think like it's pretty standard for doulas to have some very basic knowledge of body feeding and formula feeding to be able to like provide very light guidance to folks. But anything beyond that, unless you have training in lactation, my experience is we're making referrals to people with that specific training. I see your hand, Lulu.
I appreciate your comments, Janine.
Yeah, and it
get
does
to the
say above in one of the other sections, coordinating referrals to support services. Is that something we would want to repeat in that section specific to the postpartum? Or would that stand as well in terms of that sort of referral to an IBCLC?
Yeah, I'm actually a little confused because, well, Rachel, can you go back up? Because I'm trying to figure out why there are two sections that say like the same stuff. So like,
Yeah. So sorry to cut you off, Kate. A lot of states, what they do is that up above that doula services is a definition of what doula services are, so that as doula services are, the term doula services is used later on in the document. People can refer back and say, oh, we're talking about doula services later on.
oh, we're still in definitions up
This
here.
is what that means. And then there's many states. So many states have this initial definition of what doula services mean, and then have a second section around what is actually covered. It is redundant, and we can certainly pull some more of the rules from other states to see if there's ways that other states have gotten around that. But I agree that there is redundancy there, but it's one is a definition of what doula services are, and one is the definition of what's covered, which are kind of the same thing, but
Yeah, no, yeah, I think if we just like clarify in the document, like, I don't know, even like a line break here, like a whatever you call that, to make clear this is a definition section and this is like a recommendation section. Yeah. Okay, but yeah, so we're in the definition part. Should we stay in the definition part for a moment before we go down to the service part? Because that I feel like is where the big discussion is actually, under like what services are covered versus like the broad definition of services. Does that make sense?
yeah, we can certainly stay there. Shannon, you have your hand up?
Oh, yeah, thanks. Looking at bullet point number 2, is end of the pregnancy is implicit in that induced abortion services at any trimester, or are we just not going there explicitly in these definitions?
That is what those 3 words, all pregnancy outcomes,
Okay.
means.
Okay.
Yeah, we didn't put the word abortion in here.
Yep.
Pretty intentionally, but we are covered, right? That we know that doulas do provide abortion doula services, and so we've coded it under all pregnancy outcomes.
Get it. Okay. Thanks.
Yeah.
Emery, do you want to talk about this comment that you have around? I've also seen this in other places around climate disaster.
Yeah, I was reading an article on doulas in Florida who are being trained to provide climate disaster education to their clients. And it just made me think of Maine, right? So we have some severe weather conditions that quite often come up. People lose power. So certainly in more rural areas, I think as Mainers, we know these things, we know how to mobilize. But what if you have a new family that just moved here from, another state and they moved here in November and there's a big blizzard and, working with a doula, and I just think that is, as doulas are advocates to pregnant people in the community, I would guess that doulas are probably doing this already, but maybe really highlighting that this is something that we can get training on, or that doulas are sharing this information to keep pregnant people safe. Um, I certainly, as a midwife, talk to my patients about this, but, you know, I see them once a month. I might not see them during a time when, there's some sort of climate or severe weather condition coming up. So just thought as a discussion point to include that. And I'm not sure that many other states, aside from Florida, are doing something like this. So, um, it highlights some important work that we can add here.
Thank you, Anne-Marie. And Ashley, there's a comment just under that around some language change around social determinants of health. Do you want to talk more about that?
Yeah, I just at the MPCA we're trying to keep kind of a pulse on what accepted language is within our documents as to not get flagged. So just wanted to kind of point that out that we're starting to change our language around social determinants of health to state upstream drivers. That's sort of the new suggested phrase.
Yeah, thank you. I will do some more reading about that because I was not aware that there had been a change in suggested language around that.
I hadn't either. And I know we have two policy writers here, Julie and Margaret, and we're kind of always learning new words that we shouldn't be used or can't use anymore, or so I think they'll also keep track of that too. I'm assuming, Julie, you're on. Not sure if that's.
Yeah, I don't know if my microphone's working. Am I coming through?
Oh yeah, it is. Yeah.
Oh,
Yeah.
excellent. Okay. No, that is absolutely something that we'll be tracking as well.
Yeah, thank you.
Absolutely.
Rachel, do we want to scroll down a little bit? So there's this big definitions section. I want to get through a couple more of these comments. So we're going to kind of pass the meat. We'll be coming back to each one of these sections. This is not the first time we will be talking about all of this. But I do want to, we've got about 35 minutes left, and I want to kind of move through some more of these initial comments. And this one from Anne Marie is a really good one and is one of those places where, the sort of like being very specific about our language is important. And I would love to hear people's thoughts on this question.
I'm just going to mention why it kind of became a question for me, because I could just see, as hospital midwife, the birth team saying, well, what does that mean? Being an active member of the birth team, which I always see doulas as an active member of the birth team. They come in with the patient, and so yeah, they are, very active and advocating. But I just could see how an operations person or, like maternity care management person might say, well, what does that mean? Are they going to be doing, baby monitoring? And so I just think we should define it so it's more specific. Yeah.
Lulu?
I wonder if this may tie into my question, which I think is like maybe on the next page, but regarding just literally physical presence at the birth, I mean, to an extent. And my question was around, essentially failure to attend a birth. And that could be for matters of weather, but in some cases, for whatever reason, the family may not call you in. Either they make a last minute decision not to work with you, or perhaps, they get swept up in a way where somebody doesn't make the call or something. And I'm wondering, yeah, how is that handled in this setting? If you're not a literally physically present, active member of the birth team. I'm not
Yeah.
sure if that was tying into what you're discussing, Anne Marie, but I think it's certainly parallel to that.
Yeah, I guess like I usually say care team, not birth team. Because, you know, yes, because there are reasons why someone may not be at a birth in the birthing room or be there the entire time, right? Ideally, we're providing continuous support. It doesn't mean we're physically in the room, right? Like even just thinking about an induction, right? I will usually go in for the beginning of that and wait till a balloon is placed or some meso is placed, whatever is going to be happening. And then there's like a 12-hour wait usually. And so I often go home and I'm checking in and texting and I'll come back closer to when the next step happens, right? But so yeah, I think care team is more inclusive than birth team. Um, but in terms of like what that means, I guess like what I hope it means for people is that like we are, I think one thing that I think it does is like state that we have a purpose in being a part of this person's care, that we have been invited into the privacy of that person's care, right? Like so naming that like everyone on the care team is going to have very private information about somebody, and that we're communicating across like the implication of the word team to me is like we are communicating with nurses, with our client, with whoever the provider is, with an anesthesiologist, like that we're in communication with all of the other people in that team, and that is accepted as part of our role. We're not just sitting there talking only to our client, right?
Yeah, I think I agree with Juanita in the chat that we can just say that we're a member of the care team. Um, I think taking out that word active is, maybe not a bad idea. And Lulu, to your point, I think the way that billing works is there's codes for different things that you do as somebody who's providing care. And so if you are not at a birth, you cannot bill, you can't actually bill for the code as that you were there because you weren't present. And so I think that's, there will be, the way that other states have done it is there's separate billing codes for prenatal visits, separate codes for postpartum visits, separate codes for birth. It's usually kind of just one big chunk. There's a separate code for being present at C-section. So we can look at what other states have actually done in terms of coding. But there are sets of codes that are there, and certainly, providing somebody care for somebody prenatally and then not making it to the birth for some reason, it doesn't, if you're not there, my understanding is that you wouldn't be able to bill for birth. Tiffany, do you have your hand up?
Two things. I did just pop in the chat that there are codes that are separate for labor support. Sometimes this comes up for us as CPMs where, particularly during the pandemic, we may have provided care in the community setting, and then our client would move into the hospital setting for a transport, and we were not allowed to accompany them because of COVID guidelines. So there are some codes that are distinct from birth. But given the audience that we were reminded that this document is for, is it helpful rather than to say active, but to say collaborative? Is that what we're trying to convey? That there's some like collaboration, even if that collaboration at times is unidirectional, like Juanita reminded us about needing releases. And so I know sometimes as a healthcare provider, I'm a little guarded about what I say or don't say until I know that I have permission from client patient to share that information. But I wonder if collaboration is what we're going for, given the audience that this document is meant for.
That's a good point, Tiffany. Thank you.
Yeah, I guess in thinking about that, like everything, sorry, like everything every word in this document feels like it could be a whole conversation, but I think collaboration is like the goal, right? And also it feels important to uphold the distinction that the doula works for the client. Like we're billing MaineCare, but we don't work for MaineCare, right? Like our contract is not with MaineCare. Our contract is with our clients. So just in terms of like who are we accountable to, I think ideally we walk into a room and I'm always hoping that we're going to have a collaborative team feel with everybody. And we are probably one of the only member of the care team that sometimes gets shut out based on providers' decisions. We don't always get the collaboration on the other side. And importantly, again, we are accountable to our client, not the hospital, not the birth center, like wherever we are. And I wonder how to make that piece clear. And so I don't know that we need the adjective collaborative or active. Like I think care team could stay by itself, but just to say there's a tension there, like the onus is always on us to be collaborative, but there is no requirement for providers to be collaborative with us, you know? And so I don't want to I guess I don't want to go too far into this place of being like trying to anticipate how providers like wanting them to like us or accept us, I guess. Or MaineCare, right? Like I guess, yeah, I don't know. Am I making sense? I'm really sorry. My brain is very slow this morning.
Your brain is beautiful, but it is irrelevant whether or not they like us. I think the clients are most important, and I think throwing in the word of collaboration is equally as important because we do want to work with them as a team. And while we're working with them as a team, our focus is still on the family that we're supporting.
I certainly appreciate your point too, Kate. And that's what I'm very much aligned with that, which is why I said that sometimes that collaboration looks unilateral, which may not really feel like collaboration at all. But if we're saying that doulas are a collaborative member of the team, you guys are open to it. I've never seen a doula that's not open to collaboration. But I can also support taking the adjective out altogether.
Can I also add that even if we're collaborating, a physician's not going to share with us everything that they know or in their realm. And that would work the same for us. We're not going to share everything or every personal detail, but the things that are necessary for the best outcome for the family. Am I making sense? I too am brain dead.
You are making total sense.
And I think that's the thing, Juanita, right? Is that because we know that doulas greatly improve outcomes and are incredibly impactful in the course of care. I guess I don't know, we just want to sort of highlight that you guys are willing to collaborate for the best outcome, just as you said, right? Again, even if that's unilateral, but we're not defining the birth team, we're defining doulas, right? Other people who are part of the care team or birth team may not be collaborative. So, anywho, I think both Kate, you and Juanita, your brains are working beautifully.
I agree. And there is a lot of talk in the chat about ensuring that, in that definition of doula services, there is a piece there about providing spiritually or culturally congruent and responsive care. And I think we can, people that are actively doing a lot of that in their work, please comb through please comb through the document and make sure that work is represented in all of the places that it needs to be represented. And that's certainly something that we can move down into that covered services section and make sure that's reiterated and made clear, that kind of care is part of what MaineCare enrolled doulas might be doing.
So a question I have about, so the difference between the definition of broadly the definitions and then the covered services, like, are we imagining the list of covered services that are in this document are the things we are hoping and recommending that MaineCare consider billable services? Okay.
Yes.
So I think,
or things that are not necessarily billable services, but things that are happening in the context of a billable service. Does that make does that little bit of does that make sense?
No, right. So like as part of, for example, and maybe Naomi, maybe you can share more in detail, sort of an example of something you're thinking, but I'm imagining, an important spiritual, cultural, religious component of someone's labor support, right? The labor support is what's the like billable unit of care to MaineCare, but within that, part of what you're offering is this honoring or bringing in of someone's spiritual preferences, right? Or their cultural needs around labor.
I do just want to, before we get too much into the weeds with this conversation, I do just want to just highlight that little phrase at the right after it says coverage of doula services. It's including but not limited to is a powerful phrase, right? So this is like including something like that when we start to think about like actual legality, that those sometimes a couple of little words this is what is involved with covered services, but this is not the limit of those services. So I just want to like point that out before, when we're having these conversations about what we might recommend as covered services, to just make sure that this is not the complete list. This is helping the people that will write policy have an idea about what those services include. And if any of the policy people want to jump on, or Courtney,
that's what I was going to say. Yeah,
please, please feel free. You're so welcome here, and you have the expertise in this that none of us have.
I'll just say, like, this is such amazing conversation, and the nuanced language piece, as we're looking from a legal lens and even like some political pieces, like taking these services into consideration, like we can figure out those nuances a bit down the road as well, like getting the chunk of just like what these services actually are and like what they mean to folks, like really identifying what we're looking to capture now is like a super healthy part of the process here at the beginning, and we can figure out those like may include but is not limited to, like all those little nuanced pieces. I really appreciate that. That is because like right now we have a blank canvas for the most part, and we have been able to learn so much from other states, but also from this team as well. So we policy folks are just like looking for really good understanding of what this work entails, just so we can appropriately capture it. So this discussion is just phenomenal. I'm so excited to get the chats and stuff, but I would just encourage folks not to get too caught up down the rabbit holes of specifics at this point, because we will have plenty of time to flush it out and and review this language again and again to ensure that it is reflective of this incredible work and gives doulas across the state just like the platform to be able to provide services in whatever way honors their work and the family that they're working with.
Yeah, thank you, Juliana.
That's helpful.
Probably
Yeah.
very helpful, and I am certain that we will be calling on our policy folks again and again to recenter and reorient us. Tiffany, your hand's up.
That was basically my question, was to ask for help reorienting to how this section would actually be used, because that may provide clarity as to what what specifically needs to be named. So, for example, if this was going to be used, I don't know, later on down the line, if MaineCare did an audit of doula records and the doula had documented that they provided a consult that was rooted in cultural support, for example, and MaineCare is going to look to this, like, does this count or not? That's sort of helpful to know. And I think that sometimes I'm losing track of like how this section would be used.
Right, that's an excellent example. So when an audit is occurred, they pull that whatever that version of the policy was in place during the time of service. That is what is used as a reference, and they get very, very in the weeds and very specific about things matching up. So that's why, as Courtney said, like the more specific we can be, honestly, the better. Obviously we do want to leave some openness to deliver services, but we want to make sure that those services are going to be captured even in a larger description or something. So when in doubt, it absolutely will be better to include descriptors of these services, even if they're not in place. We're talking about the group doula services, right? So even though those aren't in place in Maine yet, that is absolutely something, as far as I understand, that's something that we may want to address in this policy to support that development, to ensure appropriate reimbursement when the time comes. So these sections where we're describing what are allowable services and what are non-covered services absolutely will be used to review the claims through the auditing process. And also it's helpful to provide a guide because as folks have brought up, the structure for the entity that is doula services across the state is very fluid and independent in some ways, and it's just such a unique community within the medical community. And this is also intended to be a guide. So members, for the most part, aren't going to be picking up the MaineCare benefits manual and reading this, right? It will be for the doula providers to see exactly, okay, how will MaineCare reimburse me? What will they reimburse for? And we want this to be as a very digestible, clear guide to what exactly MaineCare will cover, to ensure that there's no uncertainty, because your focus should be in providing care to members, not trying to interpret what the heck this legalese means. So,
can I ask a clarifying question as a follow-up to that? So I'm hearing, and I appreciate Juanita's comment in the chat around smudging, singing, drumming, all being culturally responsive. And I see we have cross-cultural communication. There's a few cultural sensitivity, but I'm not seeing like providing traditional healing services. And so I just didn't know if, to your point, being specific, but also broad enough that we know that each tribal nation in our state is going to have different cultural and different, various communities are going to have different cultural needs and histories and offerings. And so I'm wondering if there is something that Julie would provide that to say like culturally responsive healing services. Like, is there something that could be broad enough that could be included? Or do you feel like that's not necessary?
I think so. First and foremost, we have to see what's federally permissible, right? I don't have those answers, but whatever is permissible, absolutely, let's make it clear and let's capture that. So that way we're not sitting questioning, because like there are in other types of services that would be a non-covered service, right? So we want to make it extremely clear here that is absolutely permissible.
And I just want to say, this is hard because there's so many overlapping initiatives going on, but as part of work that I'm leading with our 1115 waiver work, we are applying for a waiver to be able to cover traditional healing services through Medicaid reimbursement. And so that will be inclusive of smudging and many other practices. So I just want to say we are looking in specifically what is covered by CMS and what is permissible. So we're pursuing that similarly. So that might be something down the road that we can bring back to this group and provide some updates of where these overlap as well or complementary.
Thank you both. I do want to ask, Julie, do you go by Julie or Juliana?
Either's fine, but Julie is usually easier. So
Okay, Julie, I just want to ask if there has been anything said in this meeting from with your ears on the policy side that you want to clarify, or sort of lingering things that you heard that you have something to say about.
I know I have lots of thoughts. I don't want to speak for Margaret, so I'll give you space, Margaret, as well, if you have any thoughts. But I think at this point, I've just have been downloading information. So hearing what, as subject matter experts, you folks are sharing, understanding how we can kind of, transfer this information into a policy format. Such we're very much at the beginning stages, so there are a lot of questions, but I don't think there are any that I need to dive into at this point. I look forward to future meetings where we're getting into the specifics of particular topics. So I'm not feeling a need to dig into anything right now.
Okay.
Margaret, do you have any other thoughts?
Well, first of all, I second everything Julie said. Really appreciate this opportunity to take this time and get all this information from you all. I also agree with Julie that right now I don't have anything, specific questions to dig into. Like she said, we don't need to figure out like every exact word right now. It's very helpful getting the sense of things that should be included, things that should not be included. If there are word discussions that we have, people have feelings about, like that's important. But there will be plenty of opportunity to tailor and work on this as the time goes on.
Yeah. I will throw out there too, sorry to advertise your accomplishments, Margaret. Margaret's been doing so Margaret is the lead policy writer on this work, and I'm here supporting Margaret because this is a big lift. So don't let anybody in it alone. But we are Margaret has been doing quite a bit of work looking at other states as well. And so what has been captured here with the team with the draft policy from 2024, in addition to some of the work that I've had the privilege of seeing that Margaret has put together, like it seems like we have a really helpful foundation to start building off of, because why reinvent the wheel if we don't have to, right? So there are obviously some really great systems that other states have implemented that are working well, that again have been captured in the draft policy that's been shared with us, and then also with what Margaret's been putting together. So I just want to say thank you so much, Margaret, for doing all of that work, and it's amazing to see the alignment with kind of like just the real world experience that this team and subject matter experts are bringing to the table in alignment with these other policies. So I think just as, from a MaineCare lens, as we start building up what these policies might look like, I think it'll be a hefty combination of research and probably bringing it back to the team to see what folks' thoughts are. And so a lot of collaboration on that front. But as Margaret was saying, like I think we're at a point where like we're just chunking out, we're writing our outline at this point essentially, so it will be a work in progress for some time. But honestly, seeing how other projects are developed, this is already looking beautiful and wonderful, and the engagement and the insight so far has been quite refreshing. So
thank you both.
Exciting. Yeah.
So. Thank you both. We have a few minutes left. Kate, you have a hand up?
Yeah, I just I was trying to pull out something that Naomi had put in the chat, and then Naomi, you didn't ever get to say anything about that. So I just wanted to circle back to you and make sure that if there was anything beyond what you had put in the chat, that you got a chance to speak on that.
Yeah, I think it's going to be like a much larger conversation that there's not time for right now.
Yeah, I agree. And just one of the things I'm thinking is like, like understanding that there's this, like, I see you, Juanita, like the federally permissible stuff, right? And that is we have to operate under that umbrella from CMS, and also that there is that little legal coverage of like including but not limited to. And I guess like part of what I'm thinking is it feels like there is real value in actually highlighting some of these indigenous practices that are important to doula work more specifically. And I think there's value in doing that even when it's covered by the, the including but not limited to, in part because of what Julie said about like audits and how those are used for audits, but also just to uplift that this work looks different in different communities so that we're not presenting a sort of like homogenous like view of the work.
Yeah, so I heard two different things. So I heard like including but not limited to, so that things could be broad and basic. But then shortly after that, I heard we need to be specific so that if it gets audited, we're not going to run into issues. So what we're going to run into is how do we include something so that it's inclusive of all five communities and respect all of those cultural differences so that it can be reimbursable to any of our Indigenous doulas so that they can be reimbursed without having battles after the fact, but not having it, 4 or 5 pages long so that it's specific enough to include everything. So that's where I'm saying it's a much larger conversation, probably outside, of this whole, like outside of this meeting. Um, I think it's gonna be a larger conversation because it's very in depth. It's not gonna fit neat and tidy into a short conversation.
So I think I can kind of answer that. I think the verbiage in a note that would have to be sent to MaineCare, I'm assuming we're going to have to keep notes. If something cultural that isn't directly laid out, so smudged with the family or supported the family. I think the verbiage around what you put in the note would also fit into the loophole to keep it legal. Am I making sense? I'm trying not to say, hey, break the law, but but I think, for example, I had done case management in my lifetime, and we were directly not allowed to transport clients. So saying something like linked individual to a doctor's appointment or something of that nature to keep it so we're staying within the confines of the legalese, but also being able to still continue to support the family in a cultural way. I also feel pretty fiery, so I don't like the idea of being told we can't support our families in this way. So I do think that there needs to be within the state a little more openness to that.
Thanks, Juanita. That's certainly not what we our goal. Our goal is not to tell you what not to do. What we want to make sure is the policy that we include gives the cover for you to do and decide what is appropriate for your communities, for the clients that you're supporting. And so with the way that I'm thinking about it is to say, when I'm saying that we're supporting emotional, physical, and spiritual well-being of the clients you serve, then you are the one that's deciding and providing that culturally responsive care. So I want to make sure my policy is protecting you and that it's giving you the ability to decide what's appropriate for the clients that you're serving. And so we absolutely are not going to limit or dictate what is culturally responsive, and we're not going to be exhaustive with each tribal nation. Say, okay, Knobscot Nation, you can only do these services, and that's not what we're going to do. I want it to be it noted that we provide culturally, that you can provide culturally responsive care, care for the whole person's well-being, and then you decide, and you're the professional, decide what that is. So that's what we're trying to say is how do we provide coverage in our policy for the expertise that you have, and we are not here to dictate tribal practices in any way, shape, or form.
Thank you, Courtney. Tiffany?
I think that this has already kind of been covered, but I'm trying to hold awareness now, having learned from Juliana and Margaret, as well as others, that I think that what we're working on is not only a section that guides reimbursement, for example, in the case of a claims audit, but will guide and support doulas in making sure that their documentation, which is not quite the same as governing or sort of mandating what practices can be done. It's just a matter of if you are providing this type of care, whether it's around infant feeding, culturally supportive or spiritual supportive care, like supporting a naming ceremony, for example, that you have the language to put that in your documentation so that a claims audit, it just passes through like, yep, this met that piece. So, and in that way, it's just a great reminder for me, and maybe you guys have this awareness already, but also like we're writing it for the sake of policy and for MaineCare, but it also the language needs to be accessible, because if doulas are going to use it to help guide their documentation, I don't know, whatever we can do to make that accessible and not overly heavy with legalese feels really important.
Yeah, I think that would be important. I guess that's my concern, that they would get hung up with those claims after the fact if it's worded incorrectly or if it wasn't included in this language. So I think that's part of that conversation, right? Like, how is it worded in this document, and then how is it submitted in the claims process? So that's part of that conversation. So.
And Naomi, we can absolutely have another smaller conversation with the doulas from the tribes to focus on this, what would feel, good for you all. And I know we're about to start the conversation about traditional healing services as well. And so you can let us know like which avenue feels best. But we certainly want to, meet with you all and hear what language feels like going to honor your practice and giving you the widest scope for you to dictate that work. So we certainly want to partner with that, and happy to have a separate meeting conversation about that.
That would be great. Thank you.
And I know we're at the the end of this meeting, and I just like thank you everybody for being so like rigorous in your thinking about this, and like generous in like offering suggestions for language, offering frames for thinking about this work. Like it's very clear that we just have the best group possible putting their heads on this. But also what we're learning is that like this is a lot of detailed thinking and work, and I know we're going to be able to do it, but I feel like this was a really good start for us to get a sense of like how nuanced we want to be and how broad we want to be. And I think that tension will just continue to appear in the work, and we'll face that together. Sarah, do you have anything you want to say to close us out?
No, just that my heart is full, and I'm really so grateful for all of you for being here with your specific expertise. And also, please, the thing that touches me the most right now is the honesty that I saw in this meeting, and continue to be fiery, continue to be honest, continue to bring all of your questions and your concerns forward, because this is exactly what we're going to need as we move through this work. So please continue to come forward with all of your honesty and your fire and your grief and all of your joy, all of the things that you bring. So just really happy to spend this time with you.
Yeah, and I mean, this is why we're together here. We're making recommendations, right? Like we don't get to write the final policy, but we get to put forth our best vision of what would serve the people that we serve. And the people we're accountable to. So this is the place for us to like dig in on this and really put forth what we most hope for, right? What we know would meet the needs of our folks. And so yeah, that's what we're here to do. And then we hand that to someone and hope that they follow it as much as they could. But yeah, so thank you so much, y'all. And Rachel just dropped the questions and concerns form in the chat too. So please be in touch between meetings if there are things you want to talk about, if you want to ask questions, like please be in touch with us. But thank you so much for your time and dedication. We're grateful for all of you. Bye, y'all.
Thank you all.